Hi, good afternoon. So yes, my name's Ben. Can everyone hear me at the back? Excellent. So I know what you're thinking. It's the end of the day, and I've clearly got the glamour slot and the glamour topic for this. Having said which, what we're going to do now is go through the paediatric ECG. With reference to the title I was given, does anyone else remember using, when they were medical students, that ECG Made Easy book? I don't know, was it 60 pages long or something? Some people either will remember it as an instrument of torture or something which was very, very useful. I guess I was kind of somewhere in between. But having said that, actually, I think there's a number of good reasons, apart from what Will's just said, that we need to think about the ECG. It's really not actually that hard, and actually, more to the point, as he's just said, he's stolen all my introduction, it's not too hard to write questions on, so it does come up, and it will come up. Also, have you got experience now of looking at the Wordle? Have you been through one of these with all of the sort of things? So you can see there's a few sort of ECG type of things coming up with this. And so hopefully my objective is that by the end of the talk we're going to have increased your confidence in this area, and hopefully you will agree with me that it's not actually that hard. We do know that people struggle with this in the exam, and also in the pre-course questionnaire that you guys submitted, it's pretty noticeable that the widest spread in confidence was for this subject, the ECG. So with that in mind, we'll try to encompass all of that today. And it's also worth saying that the syllabus for the examination does have a section which is entitled Understand How the Electrical Activity of the Heart Relates to the ECG. And that's not a mistake, it is deliberate, because you need to understand this not only for the exam, but actually to set you up in clinical practice. Having said which, so what I'm going to do is I'm going to teach you about how the ECG works. We're going to have a little think about the cellular and the molecular basis of the electrical signal. We're going to look at the constituent parts of the ECG and their relationship to both clinical practice and to diseases. So what is an ECG? Well, it's a record of electrical currents, and it's an integral of the depolarizations of multiple cells, that's the cardiac myocytes. You could measure those individually in the laboratory, but in clinical practice, their individual electrical changes are going to be far, far too small to actually measure. So the ECG is an integral of these multiple cell currents. And the 12-lead ECG is a valuable investigation. It is worth mentioning that the word lead in this context isn't the same thing as the leads you're actually connecting to the machine. So a lead in this context means an electrical view of the heart. So what have you got? This is probably familiar to many of you. There's 6 limb leads, and you generate these 6 limb leads through 4 physical connections, to the right and the left upper limb, and to the right and the left lower limb. And using that, you can generate these views. So here you've got what's the so-called Einthoven's triangle, and you've got lead 1, which is going across here, lead 2, lead 3, and then from the centre of the triangle down to the vertices, AVF, AVL, and AVR respectively. And what's really important to note is the directions of these, because that really aids your interpretation, your understanding. It's really important to have in your head a sense of how the leads are actually looking. Because what does a positive deflection on the ECG trace mean? It means that you've actually got depolarization or electrical movement towards that lead. In other words, here in AVF, so it's going from negative to positive, if the electrical movement is up towards that at any particular time, that will be recorded as a positive deflection. And we'll go through and we'll see how that makes sense. So as I said, there's 6 limb leads here, and they examine the heart in a vertical orientation. And also, there's 6 chest leads, which are positioned as an adult practice, so V1 running through to V6, and they examine the heart in a horizontal orientation. Have any of you ever been presented with an ECG which has got a V4R on it? So what's V4R? Why do you have a V4R? Yep. So you're right, actually. They do sometimes place electrodes on the back of the chest. That's and actually that's not the V4R, because the V4R position is as I've illustrated here. So it's essentially on the analogous position to the V4 in the adult one. It's V4 right, not V4 rear. It's V4 right, or nothing else. So why do we record it? I mean, technically, you should record V4R in paediatrics according to all of the paediatric textbooks. In fact, some of the references I'll give you do say, from the cardiology consultants just say, no, don't bother with the V4R. Having said which, it does crop up in exams. So the answer is that the main reason that you record a V4R is because in young children, the right ventricle extends to the right-hand side of the sternum. So if you're actually going to be trying to examine some of these anterior views with the chest leads, you put the V4R because otherwise you're not going to be able to capture some of those right ventricular views. So that's why there's a V4R. And that leads to an MCQ, which is a standard MCQ question. So how many electrodes need to be attached to a child to record an ECG with V4R? So hands up those for 10. Hands up for 11. Hands up for 12. Hands up for 13. Hands up for 14. There's a good smattering for all of those. So the correct answer is 11 because you need to, so the key question there is the electrodes that you're connecting. So they need to have right and left upper limb, right and left lower limb, plus your V1 through to V6 and your V4R. So in other words, 4 plus 6 plus 1. In terms of actual physically connecting it, you can clearly only record sort of 10 at any one time. So what's usually done in practice is you get an ECG, you record it with V1 through V6 attached, then you move the V4 to V4R and just put it on as an extension. So that's how it would typically be recorded. Right, so having had a little think about actually connecting the leads to there, let's have a little bit more of a think about the cardiac cell itself. So the cardiac myocyte is the functional unit of the heart. And in my life before I did medicine, I did a PhD with some electrophysiology and molecular biology. So I love things like the Nernst potential and Nernst equation and Goldman-Hodgkin-Katz equations and all these things which I'm sure are sending a shiver down your spine. But essentially what you need to know is that all cells have got an electrical potential across them. And that's determined by the distribution of ions across their membrane. And the three main ions you need to be aware of in the cardiac myocytes are potassium and sodium and calcium. And so just like in all cells, so the cardiac myocyte, so this here represents the intracellular portion and that there represents the extracellular proportion. Just like all cells, there's a very high concentration of potassium inside the cell, a low concentration of potassium outside the cell. Therefore, there's a concentration gradient, so the potassium wants to flux out. Similarly, outside the cell, there's high sodium, there's high calcium. There's relatively lower amounts inside, and so there's a concentration gradient for those two ions. Those two ions want to flux inside the cell. And you maintain concentration differences across the cell membrane because you've got, number one, energy-dependent ion pumps and channels as well, which control membrane permeability. And we'll have to think about some of those ion pumps and those channels as well. Other thing to mention is about the gap junctions. So these are connections which allow electrical interconnections between the cardiac myocytes, and they're unique to cardiac muscle. And they permit electrical connections between the cells such that you then get a spread of depolarization and relatively coordinated activity, and they're particularly important. So let's just have a quick think about the cardiac action potential. So this figure, number one, you'll get all these slides afterwards, but number two, this figure is just taken straight from the Theory and Science Master Course textbook. So the cardiac action potential is what we're going to have a think about now. It's represented in this figure and can be thought of in 5 numbered phases, numbered logically from 0 to 4. Don't ask me why. Not 1 to 5, 0 to 4. So we'll start off at stage 0. So at stage 0 here, is that projected? Yes, it is. Excellent. That's much easier than me turning around. So at stage 0 here, the cell is at a resting potential. And that potential is somewhere between negative 70 and negative 90 millivolts, which is predominantly determined by the potassium, because that's the main permeability across the cardiac myocyte. At this point here, when the action potential begins, what actually happens is a lot of fast sodium channels open, and there's a rapid influx of sodium inside the cardiac myocyte. And that means that the resting potential of the cell changes from being about negative 70 millivolts, which is the potassium equilibrium potential, all the way up to a positive, roughly about positive 20 millivolts, which is the sodium resting membrane potential. So that's stage 0. At stage 1, what happens next is that you get a rapid partial initial repolarization. I say repolarization because we're coming back towards the initial polarized state of the cardiac myocyte. And that occurs because you get inactivation of those sodium channels and you have a little bit of potassium efflux. But what's unique and different about the cardiac myocyte is at the stage 2, the second stage, what you then actually have is you have a lot of slow calcium channels which open. And this influx of calcium channels causes this sustained depolarization here. Before finally moving from stage 2 to stage 3, what actually happens then is that those slow calcium channels all close and you have the opening of what are called delayed rectifier potassium channels. And therefore, once again, the main permeability of the cardiac membrane becomes to potassium and it starts to come all the way back down again to the resting membrane potential. The plateau phase 2 is really important. It's number 1 unique to cardiac myocytes, and it's also really important because the fact you have such a sustained plateau means that in stages 0, 1, 2 and 3, the cardiac myocyte is absolutely refractory to any further periods. And that's important because if you think about skeletal muscle, you can get tetanic contractions, can't you? You can get tetany, whereby those cardiac muscles just go into spasm. That can't happen with cardiac muscle, which is a very good thing if you think about the function of cardiac muscle. And it means that there's a sustained contraction and a sustained period of relaxation to allow for cardiac filling. Stage 4, don't have to worry too much about. It's just stage 4 is a stage whereby the cell has returned to its resting membrane potential, but it's relatively refractory, which means that for a short period there will be a stage whereby if it receives a suprathreshold stimulus, it will undertake another action potential, but otherwise when it gets back to stage 0, that's its true resting potential and it's ready to go with a next contraction. Anyone got any questions about that? Is that all clear as mud? Stunned silence. Better have some. So stage 4, sorry. So stage 4 is just the period of relative refractory period. So it got back to the resting potential. So if we follow it through, the easiest way to read the graph is to start at stage 0 here. So it's at negative 70. It's going to initiate an action potential. So sodium flows in through the channels. It gets to 1. Those sodium channels close and it repolarizes a bit. Gets to 2 and all of the calcium channels open and sustain the plateau. At the end of 2, those calcium channels close, delayed rectifier potassium channels open, bring it down and repolarize it in 3, and then in 4 it's just re-establishing equilibrium. And when it gets to 0 again, it's exactly as it was initially, but at this stage it's differentiated from 0 just because it's ready for a suprathreshold stimulus, so it's a relative refractory period. Whereas in 0, 1, 2 and 3, it's absolutely refractory, which means that if the myocyte receives another stimulus, it's not going to do anything again. It's already within its cycle. Does that make sense? Right. So now, having looked at the sort of cellular and ionic basis of that, we'll move on and have a little bit of a look at the parts of the ECG and think how those actually compare. So, in all of the leads of the ECG, you get a typical pattern produced which relates to the movement of electrical depolarization around the electrical system of the heart. And so it starts in the pacemaker regions of the sinoatrial node, and then you get atrial contraction, which is reflected as the P wave. After the P wave, there's the PR segments, or the PR interval. Here is this larger component. And that is the period during which that electrical depolarization is moving from the AV node down the bundle of His, the bundle of branches, the Purkinje fibers, to the ventricles. Then there's the QRS complex. So the first downward deflection is the Q wave, which may or may not be present in all leads. The upward deflection is the R wave, and then the next downward deflection is the S wave. And that QRS complex reflects the ventricular contraction, ventricular depolarization, and then finally the T wave, which reflects ventricular repolarization. You may or may not see a U wave, which is particularly notable in certain circumstances, particularly when there's a bradycardia or a relative bradycardia, so there's actually enough space on this isoelectric line to see it, particularly in young, very fit sort of children or athletes, and in adult medicine and athletes you tend to see a U wave, and also when you've got certain circumstances like hypocalcemia and hypokalemia. So let's have a little think and look through all of these components of the ECG first of all. So we'll start off with the P wave, and as I've said, the P wave, that represents electrical activity. So the heartbeat's initiated from the SA node. If you remember, that's the primary pacemaker. Those are the pacemaker cells which have got the fastest intrinsic rhythm. You remember that the SA node has its own rhythm, the AV node has its own rhythm, and then if you go down into the Purkinje fibers in the bundle, some of those cells there also have a rhythm. But since the SA node's intrinsic rhythm is fastest, usually that's the primary pacemaker. So in our circumstance, without pathology, the heartbeat's initiated from the SA nodes. It proceeds inferiorly, down there, to the AV node. And that's important because that then means is that the atrial contraction actually commences from the AV node. That's located at the base of the right atrium. And that means that the actual atrial contraction itself starts from the AV node, which is the base of the right atrium, and then spreads to the left atrium. So the initial portion of the P wave is from the right atrium, and the terminal portion of the P wave is from the left atrium. And why is that important? It's important because... Sorry?
Do that a little bit again.
No probs.
Sorry.
Yeah, that's fine. So what we're talking about is we're talking about the electrical activity of the P wave. So the SA node will initiate it, and the activity will move down to the AV node. That's not really picked up on the ECG. The P wave picks up the large atrial contraction, which starts here from the AV node, which is in the right atrium. And that means that if you think about the atrial contraction spreading out from the right atrium, the right atrium will tend to contract fractionally before the left atrium. Generally speaking, the atria kind of act as one, but actually the first bit of the P wave is the right atrium, and the second bit of the P wave is the left atrium, if you had to sort of be very, very precise about it, because the right atrium is where the AV node is located, and therefore that's where the P wave starts. Does that make sense? And we'll come on in a second to why that's important. So what can you see about P waves? Well, the main things to think about are P wave can be abnormal in terms of axis, amplitude, duration, or morphology, so the shape. The normal amplitude of the P wave is less than 3 millimeters, and tall P waves represent right atrial enlargement, or so-called P pulmonale. Peaky P waves, a lot of ways people of remembering that. So that tall P waves are right atrial enlargement. However, if you've got wider P waves, because the normal duration is less than 90 milliseconds in children or less than 70 in infants, wider P waves reflect left atrial enlargement. And that's because of what I've just said. So if the P wave starts in the right atrium and continues in the terminal portions in the left atrium, if you've got left atrial enlargement, that's how it manifests itself. Does that make sense to everyone? If you just think about it, the beginning of the P wave is kind of tethered because that's where the pacemaker is starting it. If you've got a tall peaked P wave, that's because of right atrial hypertrophy, whereas if it extends more out here, because that terminal part is left atrial depolarization, therefore it's left atrial enlargement. If you get both tall and wide, then it's right and left atrial enlargement. And if you actually see a bifid P wave, that means that there's some electrical problem between the two atria, so you've got some degree of asynchrony. So when you break it down like that, actually it's quite simple, isn't it? Tall, right, wide, left, both, separate. So moving on next from the P wave, we've got the PR interval. You need to memorize, no, you don't need to memorize these figures. They are there only to illustrate that the PR interval varies with number 1 age and number 2 heart rate. That's all you need to remember. Yes, I mean, there's things in adults saying it must be less than 200 milliseconds. Just, it varies with age and it varies with heart rate is the main thing you need to know about the PR interval. Having said which, there are, and this is not really for us this is something we might be sort of talking about our cardiology colleagues to make a distinction about if it's short or if it's long. There are a few important things which go along with short PR interval and long PR interval. So So the PR interval can be abnormal because it's either too short, and that's as occurs in either pre-excitation or glycogen storage disease. It could be too long, and that's because of AV block, or it could be variable, because normally you'd expect the PR interval to be constant. The two most common causes of variable interval PR are Mobitz type 1, or so-called Venkeback, or a wandering atrial pacemaker, which we won't talk anything more about. So, short PR interval. The main thing to realise is that as the electrical activity moves from the AV node and then down into towards the ventricles, there's a natural slowing of that as it passes from the AV node through the bundle of His into the bundle branches and the Purkinje fibres. So if you've got normally there's a relative electrical insulation between the atria and the ventricles, so it's much faster for all of that to pass through the His bundles, etc. Having said which, if you've got some aberrants or accessory pathways in there, they will tend to transmit the electrical activity much faster because there is this intrinsic slowing down which occurs in the bundle of His. And so you get pre-excitation when the ventricles receive a stimulus and they get activated in advance of the natural slowing of the AV node. And the most important thing to know about that is that this is what's occurring in Wolff, Parkinson, White. So the cardinal features of the Wolff-Parkinson-White syndrome are that you have a short PR interval. So here, this is the P wave. Nope, so excuse me, it's not the P wave. This is the P wave, and this here is the QRS complex. And you can just see how close the P is relative to QRS. And you can also, I hope, appreciate that there's a little bit of this slurring here of the QRS complex. And what that really sort of is because that there's some portions of the ventricles which are being pre-excited, and so actually you've got that relative widening of the QRS, which manifests itself as the delta wave. Wolff-Parkinson-White's really important because of its association with AV re-entry tachycardias. And they're important because they're the most important form of supraventricular tachycardia in infants. So about 80% of SVTs in infants are because you have a re-entry into the AV node. And the other thing to say about Wolff-Parkinson-White is that there's a real risk of getting ventricular fibrillation when you have atrial fibrillation. Because if you think about it, you don't have that normal slowing down. Normally, if you don't have Wolff-Parkinson-White, if you have atrial fibrillation, it doesn't really matter because your AV node in your His bundle is regulating what gets through. But if you've got a short circuit and accessory pathway, all of those can be transmitted, such that atrial fibrillation can lead directly to ventricular fibrillation. And that's also important because there means there's a couple of contraindications. One of those is digoxin. So what digoxin will tend to do is it will tend to decrease the refractory period of the accessory pathway. And that's why digoxin should not be used in children with Wolff-Parkinson-White. And you say that, there might be an MCQ about to come up with that on it. Also, just linking back into what we've just talked about, so verapamil is also relatively contraindicated in Wolff-Parkinson-White, and that's because it increases the refractory period of the AV node, which is effectively the same thing because it means that impulses are more likely to go down the accessory pathway. So, MCQ time. And this is a horrible looking question, isn't it? But actually, I think we can answer this now. So, regarding Wolff-Parkinson-White syndrome, which of the following statements is correct? So, we'll go through this and we'll have a sort of a yays or nays for if it's true, for which you think. So, PR interval prolongation is a hallmark of the ECG. No, it's shorter. I just said that. After resolution of AV re-entry tachycardia, delta waves are rarely seen on the ECG. So no, they're commonly seen. Well, no, we'll rephrase that because 50% of AV re-entry tachycardias are due to Wolff-Parkinson-White. So 50% of resolution of AV re-entry tachycardias, you'd expect to see delta waves. Wolff-Parkinson-White is very rarely associated with supraventricular tachycardia in infancy. Everyone happy with that? So it is associated. So 80% of SVTs in infancy are because of AV re-entry tachycardia, of which 50% will be underlying Wolff-Parkinson-White. In other words, 50% of 80, so 40%. Verapamil is a useful treatment for Wolff-Parkinson-White. Nope. And digoxin treatment is contraindicated in children with Wolff-Parkinson-White. True. There we go. Gosh, that's a horrible question though, isn't it?
So can you explain?
Yeah.
I'm really sorry.
That's right.
Resolution of AV re-entry bit.
Yeah, sorry, it's a slightly tortuously worded one. So all it basically is saying that if a child's had AV re-entry tachycardia, are they likely to have Wolff Parkinson White? That's what the question's asking. It's possibly not the best worded question. That's my fault.
And it shows how hard it is to write these questions. Actually, it is really, really hard to get all 5 steps and only have one that's right. We're now going to best of 5s. And so this was doggle to write. It's a multiple true false, wasn't it, Ben? You'd be dead easy.
Well, for the rest of the talk, they're all multiple true falses for exactly that reason.
So it shows how very, very hard it takes ages to learn that napkin writing.
It's ages to learn how to answer.
Maybe. Hopefully not. Hopefully we'll shorten that period of time.
Right, so there we go, yeah. So let's move on then just to long PR intervals. So essentially what we're talking about here is atrioventricular block. As you probably all remember from other books you've read, or the ECG Made Easy in fact, you can classify this into first degree, second degree and third degree. So the main thing about first degree is that what you've got is prolongation of the PR interval, which you conserve your transmission of impulses. So what I'm saying is the PR gap will be longer, but all of your Ps will be leading to QRSs. That's the hallmark of first degree. Maybe it's normal, can be associated with all of these things here. I won't kind of go through and read the list, apart from just to explain what some of those things are that I've used abbreviations for. So congenital heart diseases, Ebstein's, is where you have what's called right ventricular atrialization. So it's the right atrium to right ventricle. That valve between the two is moved into the right ventricle. So effectively, the way to think about it is half of the right ventricle functions as right atrium. Why does that fit with this? Well, because what we're talking about in AV block is in that region. So if you've got a congenital malformation in that region, you're going to mess up with your electrical transmission. This next thing, ECD, is endocardial cushion defects. Exactly the same thing. Your endocardial cushions are all around your AV node. ASD, atrial septal defect, any defects around the AV node. So basically, what congenital heart diseases give you long PR interval? Ones which are in the same place. The important thing about first degree is only really that it can progress to higher degrees of block. Speaking of which, second degree block is what we'll talk about next. So, divided into Mobitz type 1 and Mobitz type 2. So this one here is the ECG demonstrating Venkerbach phenomenon, or Mobitz type 1. So what I hope you can see here is that you've got a P wave here, followed by QRS. Whoops, done that again. And a P wave followed by QRS, slightly longer PR interval. P wave followed by QRS, slightly longer PR interval. And then a P wave, which drops a QRS, and then it captures it again. So Venkerbach, or Mobitz type 1, the way I always remembered it was Venkerbach begins with a W, and the PR interval widens, or lengthens, but doesn't work with a mnemonic. So Venkerbach and widening, and eventually you drop a beat. Mobitz type 2, by contrast, is one where you tend to get dropped beats. And so the way to, there's other ways of remembering that, you can do a mnemonic, but essentially that's important because it can be related to structural damage to the conducting system. And it's Mobitz type 2 which can progress onto third degree heart block, or can sometimes need pacing by itself, depending upon how bad or how severe the Mobitz type 2 is. This ECG here is third degree heart block. In other words, there was a complete dissociation of P waves and QRS. So here's a P wave here, here's a QRS, but actually that's just coincidental, because here's the next P wave hidden in the T wave. Here's the next P wave right before the QRS, and you can just see, so there's complete asynchrony of your P waves and your Q waves, and that's total or third degree heart block. That may well require pacing, depending upon clinical condition. Moving next on to the Q wave. So, the important thing to remember for the Q wave is that that occurs because of depolarization of the atrial septum. And because of that, you can think about which leads it's normal in. I don't really have time because I think we're running a little bit low on that to sort of go through. It's normal in those leads there, which effectively, if you think about where they're looking, particularly let's think about V4 and V5 and V6, they're looking laterally at the heart. The depolarization of the septum moves from left ventricle to right ventricle, and so you've got electrical movement away from where those leads are looking, and that's a downward deflection, isn't it? The same thing will happen with where V2, lead 2, lead 3 and AVF are looking. So you'll always get the downward deflection, and that's why those leads have a Q wave. The other leads just don't happen to be looking in the right electrical angle to have that downward deflection. That's the way I've always remembered which ones have actually got Q waves in it. It's important, not because of like Q waves equal MI, as they pretty much do with adults, although you can see that with Kawasaki's. You can get myocardial infarction secondary to Kawasaki's disease. But it's important to know which leads it's normal in, because in the other leads it's essentially pathological. There's a couple of examples which do come up in the exams. There's Al-Kappa, and that stands for anomalous left coronary artery coming off the pulmonary artery. So you think normally the coronary arteries come off the coronary sinuses in the aorta. But in Al-Kappa, the left coronary artery is coming off the pulmonary artery instead. And that leads to lateral lead Q waves, especially AVL. And another thing you just have to learn is V1 through to V3, congenitally corrected TG transposition of the great arteries tends to have Q waves in those anterior chest leads. So thinking now instead of just the Q wave as the QRS complex as a whole, so while the Q wave itself is septal depolarization, the QRS complex is whole ventricular depolarization. The duration should be less than 120 milliseconds, and it can be prolonged in a number of instances. If you're thinking about your ventricular tachycardias or your ventricular ectopics, they're very wide, aren't they? Because they don't follow through the normal His-Purkinje bundle branch system, and they're therefore very wide. Same sort of thing applies if you've got a pacing wire in. That will lead to very wide ones. You can also get prolongation or widening of the QRS complex in pre-excitation, so Wolf, Parkinson, White, as we've already spoken about, and in bundle branch blocks. You might remember from the ECG Made Easy book all about William Marrow and those mnemonics. All you really need to know in paediatrics is that right bundle branch block is much, much more common than left bundle branch block. And the hallmark of that is the RSR, which is illustrated just there. Yes, that's all I wanted to say about that. Next thing about the QRS is thinking about axis. There's multiple ways of determining that. The way I've always done it is just by calculating a vector between lead 1 and lead AVF, but there's methods of successive approximation, there's all sorts of little mnemonics and ways of doing that. Whichever works for you, it doesn't really matter which. And practically, it's something you might need to do in your clinical practice. I don't think necessarily you're going to be sitting there calculating the exam. But what you do need to realise is that the normal axis of the QRS complex varies with age, as illustrated here. And the variation of ECG features with age, such as the QRS axis, is one of the really important things that's different in paediatric ECG compared to adult ECG. And you can really easily understand it if you think about what happens from the newborn baby and in utero all the way through to older children. So in utero, the lungs are filled with amniotic fluid, and therefore the pulmonary vascular resistance is very high. And consequently, the right ventricle is very, very thick and very strong to pump around that very high pulmonary vascular resistance. Whereas if you think about it in utero, the systemic vascular resistance is very low because it's the placental circulation that's doing that. So relatively, the left ventricle is very, very small and very, very weak. And that's completely opposite to sort of how we think about it. We think of the left ventricle being very strong, the right ventricle being very, very weak. Actually, it's the opposite way around in children. And that situation doesn't really tend to reverse until they're about 3 years of age. And that's why the cardiac axis here is in a different range. So you think about it in adults, where the range tends to be around here. Actually, there's relatively much more right axis deviation in smaller children. And there's right axis deviation because of that in utero position, where the right ventricle had to be strong to overcome the high pulmonary vascular resistance because of the amniotic fluid. That brings us on to the last thing, which is a concept you may not have come across before, which is about the RS waves and what's called RS wave progression. And this is just looking at the RS waves in the chest leads, V1 to V6. And here we're just going to look at V1 and V6 because they're the most obvious ones. In exactly the same way, because the right ventricle predominates electrically and in contractility in the newborn baby, that means that you get very, very pronounced R waves in V1 and very deep S waves in V6. Whereas by the time they get to be 3 years of age, they've achieved the adult pattern, which is that the left ventricle is now predominating over the right ventricle. And therefore, what you actually have is you have the opposite situation. You have S waves in V1, and you have R waves in V6. And there's an intermediate pattern here, which tends to be between 1 month and 3 years of age, where you tend to actually have predominant R waves in both V1 and V6. And this is important because it leads to this concept of abnormal R wave progression. Because if you have a situation whereby the right ventricle stays predominant because of right ventricular hypertrophy, that means that you'll tend to see that much more juvenile, neonatal or transitional pattern much longer. So if you're seeing that sort of intermediate pattern in a 4 or 5 year old, that's a feature of right ventricular hypertrophy. Does that make sense? Excellent. So we're getting towards the end, almost to the end of the beat now, and on to the T wave. What's the T wave represent? It's ventricular repolarization. And the most important thing you need to know about the T wave is that the pattern varies with age. So in the first week of life, T waves are upright in the precordial, in other words, the chest leads. After 1 week of age, the T waves invert and flip over in V1 to V3. And this is the so-called juvenile T wave pattern, which is highlighted by the pink arrow there. This T-wave inversion in V1 to V3 persists until they're roughly 8 to 12 years old. Technically, there's different ages at which each of them invert. You don't need to know that, but you just do need to know it's around 10 years of age, you tend to get that juvenile T-wave pattern. And the reason that's important is because otherwise it can sort of worry you about what's going on with those T-waves, but also it's significant because this leads to the other feature of right ventricular hypertrophy, which always comes up in the MCQs, which is an upright T-wave in V1 before the age of 10 is a classical feature of right ventricular hypertrophy. And if you didn't know about the juvenile T-wave pattern, you wouldn't appreciate that that was abnormal. Also, just about the T-waves, if the amplitude is increased, so you've got tall and peaked T-waves, that can be due to a number of different causes. Hyperkalemia, I think we're all familiar with, as well as things like left ventricular hypertrophy. There's a number of causes of flat or inverted T-waves there, and you can get very deep, profoundly deep T-waves in things like raised intracranial pressure because of the reflexes that occur there. And lastly, but not least, the QT interval. So, the QT interval. First thing to say is, where is it measured from? It's from the start of the QRS deflection until the very end of the T-wave. In other words, the point at which the T-wave returns to the isoelectric baseline. It varies with the heart rate, and that's why, actually, we should really be talking about the corrected QTC. I'm sure you probably all get those on the ECGs when you get them printed out. It's really good practice when you're on the wards. Always calculate it manually. Never, ever, ever trust what the machine tells you. Always just calculate it manually using Bizet's formula, which is the QT interval divided by the square root of the R to R interval. The normal range is up to 440 milliseconds. And there's a number of reasons why it can be prolonged, which you can simply subdivide into either acquired, which predominantly is things like electrolyte disturbances and hypothermia, or, if not acquired, the congenital long QT syndrome. It's recognised that there's many genetic causes of the long QT syndrome now, and there's lots of different gain of function, loss of function, ion channel mutations which have been identified for this. And the treatments now actually really depend upon which genetic subtype of the congenital QT syndrome you actually have. The reason the long QT syndrome is important is because of the risk of ventricular arrhythmia, and that's why you really should always check the QTC manually, every ECG that's put in front of you to have a look at. So, last but not least, let's have a look at a multiple stem true-false question. So, let's go through these together. Regarding the pediatric electrocardiogram, are the following statements true or false? So, Mobert's type 1 can progress to complete heart block and may require pacing. So the overwhelming answer is false. Everyone agree with that? So it is false. That's because Mobert's type 1 is Venkeback. That's where you have the widening PR interval with dropped beats. Mobert's type 2 is the one which implies damage to the conduction system and tends to be the one which progresses to third degree and may require pacing. What about the next one there? T-wave inversion in V1 to V3 is a normal finding in a 6-year-old child. Yep, that's the juvenile T-wave pattern. Presence of Q waves in AVL is usually pathological. Not sure about this one, are we? So Q waves, they're awkward, aren't they? Remember, it's the ventricular septum depolarizing from left ventricle to right ventricle. So, what I would suggest doing is, when you get the talk back, go and have a look at where the different leads are, 1, 2, 3, AVF, AVL. So essentially, the Q wave shouldn't be in the AVL. That's the one which is associated with Al Kappa. QRS axis is usually more to the right in younger children than older children. Because in younger children, they've still got that neonatal position where they've got right ventricular hypertrophy, right ventricular predominance because of the high in utero pulmonary vascular pressures, resistances. So yeah, they tend to have right axis deviation, which moves to the left, and the same reason the RS progression progresses as they get older as well. And finally, ECG changes seen in right ventricular hypertrophy include inverted T wave in V1, right axis deviation, and a more mature RS progression than expected for age. That's one which you'd have to sit down and really think about, isn't it? Any thoughts? I'm not going to put anyone on the spot for that one. I was thinking about asking Will, but I thought, no, that's deeply, deeply unfair. It's an evil question. So, no, it was a non-inverted, so an upright T wave in V1, and so it's a more immature RS progression than expected for age. And the way to think about it is, if you've got right ventricular hypertrophy, that's the neonatal, the sort of the post-fetal stage, isn't it? So in the RS progression, we'll go back to the slide. In the neonatal sort of period, you've got this predominance of the R waves here and the F waves here because the right ventricle is much, much stronger electrically than the left ventricle because of that high pulmonary vascular resistance in utero. In the same way that if you then, as you subsequently expect to get as you go down, the left ventricle predominating, if you've got right ventricular hypertrophy, that means that the right ventricle will relatively remain with that progression for longer. And so that's referred to as an immature RS progression. Do you see what I mean? Because if, let's say, in a 3-year-old or a 5-year-old, you've still got that neonatal type of picture, that's an immature progression, and that would be what you would see with right ventricular hypertrophy. So, what did we cover? Well, I did say I was aiming to increase your confidence in that. Sorry, it's possibly a bad question to have ended on. But anyway, what we did try to cover was how the ECG worked. We looked at what constituted the electrical signal. We thought about the constituent parts of the ECG, from the P to the QTC, and some idea about how they related to diseases.